talk. I may take a little longer than the time planned. So let's see, I'll try and run through as quickly as possible. The only thing is, um, sorry, but it is not just from my perspective as a neurologist or as somebody who's interested in palliative care. It's in fact a little wider than that. It is from the perspective of citizen. This is because um, what happened? Sorry, just give me a minute. I think, yeah. Was there any difference when I moved this, or both are okay?
Both are okay. We can see the entire slide. No worries.
Yeah, I'm only trying to see if I can. Yeah, I've got my arrow. Right. So I'm speaking also from a citizen's perspective, and it's important for all of us to understand about death, dying, because eventually, what do we all worry about? We worry about dying with pain and suffering. So this famous joke from Woody Allen is that I'm not afraid of death. I just don't want to be there when it happens. We'll skip this. So we all think about quality of life, which is well-being, physical health, social relationships, and all those. We don't really think about the quality of death. But if it has been looked at, it has been looked at as a good life till the very end, with minimal suffering. But the thing is that suffering has to be measured, and then it has to be, you can work on improving. And now there is also the question of patients' rights at the end of life. Uh, Now, we know that palliative care is applicable to all serious health related suffering, but we need to define certain terms here. End of life care is typically taken as months to 1 year. Terminal care is a shorter period than that. And when physiological parameters, which are irreversible, show that death is inevitable within the next uh, days or so, we call it actively dying. So the definitions that we have are not really as precise as one would wish. So terminal illness is one from which recovery cannot be expected with available treatments, and death is considered to be unavoidable in the foreseeable future. I'm a neurologist, which means that when I diagnose dementia in a patient, maybe death is still about 10, 15 years away, but it is still a terminal illness. But end of life care is an approach to a terminally ill patient where you shift the focus to symptom control, comfort, and quality of life and quality of dying. And at that time, treatments aimed at cure or prolongation of life can be stopped. So you can see that there is, although they are not precise, the basic sense is something that you can get. So how do we die? And this is where the trajectories at the end of life become important. This first came out in a paper in 2002, but subsequently it has been looked at everywhere. It might surprise you to know that sudden death is actually pretty uncommon. In fact, after the age of 50 years, less than 10% people die suddenly. Our long-haired president died at the ripe age of 84 or 85 while he was lecturing. But to get a death like that at that age, it takes a lot of punya. And you have to, that he did that. What about terminal illness? Now, if you look at this trajectory, it has been called the waterfall trajectory. Because once, say for instance, a tumor, once a certain amount of tumor burden is reached, then after that, the decline is progressive and it is fairly foreseeable. Malignancies tend to peak uh, in the 60s, ages of the 60s, and cancer affects about 20% of us. And I think you know the person who is there in this photograph. And then you have the trajectory of what is called organ failure. Now, this is somebody who is touching the 70s or in the 70s who has uh, either kidney, heart, lung, liver failure in the setting of bad diabetes, blood pressure, and so on. And in this trajectory, they have a crisis, go into hospital, come out, not as good as before, again, in, out, until finally they pass away in a crisis. And this affects about 15% of us. Note that the picture here is that of the common man because VIPs get organ transplants. Anyway, then you have somebody who begins illness at a pretty low level of functioning, as also even in the looping trajectory, but here even lower. And they dwindle gradually down until finally they pass away, maybe a decade after that. And this affects people in their 80s, 90s. We call this the dwindling and the frailty trajectory. And this will affect about the majority of us, about 50%. And if you remember, Atal Bihari Vajpayee, um, we heard nothing of him after he lost the election in 2004 until he passed away in 2016. But there is another trajectory which has been identified now. It's called the fifth trajectory. And in the fifth trajectory, you have somebody who's doing very well, who's functioning well. And their brain is hit by a stroke or a truck or a bullet or whatever. And they decline and stay in a low level of function until death. It's important to note that in healthy elderly, this can be a systemic event like hip fracture. And that's not often recognized. But once they are here, then again, palliative care is probably relevant. Now, in all these trajectories, the important thing to understand is that we can actually foresee and foretell death. And this was a duty that the physician has had since the time of Hippocrates. It's considered part of our calling. The problem is that patients today are empowered and they want us to prognosticate honestly, accurately, and optimistically, and we find that very difficult to do. Can we predict 1 year mortality? Yes, you can. I mean, when you're predicting mortality, although 1 year is not very exact, it's just about 60%, depending on the number of points you get. So, for instance, if you have a elderly male who needs assistance with all activities of daily living, so 1 in 5, 6, and on top of it has congestive heart failure, so 8, has a more than 60% 1 year mortality, which means that if you statistically, if you look at it, by the end of 3 years, he has a 95% chance of not being there. So all of this should tell you that only a minority of deaths are unexpected, and the majority of deaths can be expected, can be planned for, and people can live and die in the place and manner of their choice. This has been best worked out by the gold standards framework, which is a non NGO in the UK, and it is heavily used by the national health system there, and I'll explain that to you. So, how do we recognize terminal illness? The first is what has been called the surprise question. If you intuitively guess that somebody would not survive, then there are general indicators of decline, then there are specific clinical indicators, and then there's a question of decision. So let us look at the surprise question. And the surprise question is, if you answer no to, would you be surprised if this patient were to die in the next year? Actually, you can change the time frame and make it months, weeks, days, but this is an intuitive answer. And you're putting together clinical, comorbs, social, other factors to get a whole picture. And the accuracy ranges between 70 to 80%, a little higher in oncology than in non-oncology, but nevertheless, fairly high. And it probably gets better with experience, not with degrees. What about general indicators? So anybody whose activity starts to decline to the point that they are in bed or the chair more than 50% of the day and are dependent on most activities of daily living, you look at somebody who is now not able to function at the level that doing so, and that is an indicator. And here again, you can assess this fairly systematically. This is the Karnofsky performance score, and if you look at somebody who's 20 to 30% functional, you are looking at a time span of survival in months. But the other indicators of mortality in the medium term, comorbidities. So anybody who has more than one illness going on. Of course, if it is cancer, then it is uh, purely the tumor burden that seems to determine it. But other than that, it's comorbidities. And then somebody who has advanced disease. I mean, what do you mean by advanced disease? Unstable, uh, increasingly complex symptom burden. In Parkinson's, it could be as much as severe constipation going on to obstipation. I've had patients who died with that because constipation led to obstipation, obstipation led to uh, aspiration, and that was it. Or decreasing response to treatments, uncontrolled diabetes, ILD requiring home oxygen. Then general indicators like progressive weight loss. Serum albumin is a significant marker. Repeated unplanned crisis admissions, and then sentinel event. Sentinel event could be, like I told you about the hip fracture, but it could also be the loss of a spouse. For specific diseases, of course, you can get more specific, and you will see here that it is most predictable for cancer. This is because once cancer progresses beyond a certain point and tumor burden is increasing inexorably, the only additional thing that can change or make it worse is the presence of multimorbidities. And if somebody is spending more than 50% of their time in bed, survival is expected to be 3 months or less. If you look at organ failure, it becomes relatively more erratic. For heart disease, so that's why you see there are so many indicators in each of them. If you look at liver disease, for instance, somebody who has hepatocellular carcinoma has no chance of a liver transplant and has complications of uh, cirrhosis. These are the patients who are likely to survive for short periods of time. But again, the it's not as precise as for cancer. And in terms of neurology, it is quite complex. Um, if you look at each disease will have differing indicators, but even then we do have certain broad uh, determinants which help us figure out. And here you have to remember that in for neurologic decline, it's a combination of decisional as well as multimorbidities. So somebody who's progressively deteriorating with symptoms which are complex and difficult to control, with swallowing problems or speech problems, uh, you then have the option of deciding not to keep them alive. So why do I say that? And I'm giving you three examples. Barbara and George Bush both passed away in 2018. Atal Bihari, almost of the same age, basically all three in their 90s, passed away in August. The two of them, Barbara and George, passed away in their own beds, literally in Darbar, surrounded by families, dogs, everybody. Atal Bihari died alone in the AIMS ICU on ECMO on the 16th of August, the day after the last Independence Day speech of the previous parliament. So uh, let's look at this in terms of cases. So the first case that I have taken is actually neurologic. This is well, uh, this is a combination of patients of mine, a retired bureaucrat who first was diagnosed to have early dementia, treated for mild depression, didn't get any clear answer from his neurologist at a stage when he was capable of asking and understanding. Before the dementia was diagnosed, he had actually reduced his commitments because he had, in some ways, realized that things were going downhill. And as so many of us, son and daughter living in the US. So, over the next 2, 3 years, he showed this gradual decline. So, in 2015, his daily routine was independent, but was he had repetitive questioning. Then incidents started to happen in 2016, needed more and more supervision. And by 2017, there were behavioral issues. So there were intermittent angry outbursts, there was nighttime wandering, and so on. And then in 2018, beginning of 2018, he developed a delirium due to urinary tract infection and was found to have a hyperfunctioning detrusor. But when he was discharged, he now needed full supervision for basic activities, but he was mobile in the house and his conversation was limited. Now the wife began to ask, Ab kya hoga? What will happen now? And again, they did not get much of an answer. At the end of that year, he came in again with encephalopathy. And when this was discharged after his sodium was corrected, he was completely bedbound and nearly mute. 2 months later, he came in with recurrent seizures. He was treated with levetiracetam and phenytoin and was intubated. And the seizures were controlled. There was no obvious metabolic cause, so we presumed it was dementia. He was not my patient at that time. And he was weaned off the ventilator, and by default, he got a tracheostomy. But when the time came in to put in a peg, the family kind of said, "What is happening?" And this was the time that palliative care got involved. Finally, a peg was put in and he was discharged on day 28. But on discharge, he was effectively in the persistent vegetative state. And the US based son actually asked, could we have involved palliative care earlier? In fact, if you look at it, uh, he received a diagnosis of dementia how many years ago? And at that time, you could have said that this was a terminal diagnosis. Anyway, he developed bed sores, and another 2 months later, he vomited, aspirated, and died. So remember that there are multiple missed opportunities in this story. At the time of diagnosis, the roadmap ahead could have been told to him. By the time of the first admission or the second admission, we could have started figuring out that he was now entering the last stage, and that we could have begun to focus on comfort and avoiding future hospitalization. In fact, when he came in for seizures, maybe we should not have admitted him. We certainly should not have intubated him, and definitely not done a tracheostomy. And his suffering or his family's suffering could have been cut short by 2 to 3 months. In contrast, look at this patient who had a malignancy. Uh, Again, only daughter in the US develops CA colon and goes to through an oncosurgeon and then to an oncologist, gets a left hemicolectomy. Again, not much discussion with the oncologist because the oncologist, so often we do this. If the patient is in front of us and we talk to the relative, because we can't look the patient in the eye and say, yes, you have cancer and we treat it. So he went through chemotherapy, which was well tolerated. And what the oncologist didn't know is that soon after this, after the chemotherapy started, um, the US based grandson insisted on a palliative care physician becoming involved. So after that, he went through 3 monthly follow up. But uh, at the end of the year, unfortunately, there were mets in liver and lung. And he was given a survival of about 4 months. But with palliative chemotherapy, he could probably pull on for another 1 to 2 years, which he said, no, thank you. And he chose palliative care. Palliative care did home visit and things were set up at home. And now look at how this ended. By 2018, prolonged discussions with the palliative care team, with his wife and grandson participating. The grandson has just gotten a new job, but he got leave, flew to Mumbai to take care of Nana, and made sure that things were done right for his grandfather. Uh, in 2018, he was literally dying, and the daughter could only now come in. And literally, he held on until he met her, slipped into coma, and passed away. So, see the difference. In neurologic or non-oncologic death, the trajectory is erratic or prolonged. You may have recurrent admissions. Unfortunately, in dementia, the patient loses control, so there is no, your personhood is lost. And too often, there is expensive and avoidable ICU care at the end. In cancer, the trajectory and prognosis is relatively defined, admissions can be avoided, and patients and family can retain control. So, but what is the diagnosis of old age? Remember that whatever we may do, we are not expected to live much beyond 80 years. And so we have the importance of sentinel events. Look at this lady. So in 2014, she and her 87-year-old husband decided to move and live near her only daughter. She used to live in Bombay, and she had poorly controlled diabetes and she had been having issues. So they settled into a new home, and the daughter insisted on servants. She was pretty active socially. In April 2016, almost about 1.5 years, a little over 1.5 years later, she had a febrile diarrheal illness, needed admission, but was okay. Uh, Later that year, she had a fracture neck fever, needed hip replacement, and now she started to get more dependent. Um, six, you know, 4 months later, the husband developed. He was by then obviously touching 90, past 90. He uh, developed pneumonitis, sepsis, multi-organ failure, and he was gone. The thing is that this, he actually did not get even intubated. This was because DNI was confirmed, and um, this was because both husband and wife had spoken to their daughter after her admission for fracture neck fever, and they had very clearly said no heroic measures for either of them. And then once this was over, the granddaughter moved in to live with her, which helped the old lady uh, to some extent recover from her grief. But in another 7 or 8 months, she developed multiple superficial soft tissue abscesses. Remember, she had poorly controlled diabetes. In fact, she was admitted twice to be given IV antibiotics, but by March 2018, well, we had run out of antibiotics. So she was discharged for home care, and she asked, "What is happening to me?" And was told that the antibiotics are not working, and we are going to keep trying with this. So she said very clearly at that time, "Okay, I don't want to go to hospital." And although she had a lot of pain, could have used morphine, she refused any painkiller stronger than paracetamol. By end April 2018, her activity started to get reduced. She was just about to able to feed herself. Her appetite, intake of food and water came down. And about 3 months after uh, the the IV antibiotics were started, she became confused, a little restless, moaning, cold hands and feet, became incontinent. And 3 days later, after we noticed this, she stopped speaking and then stopped breathing, and she was gone. So, in all of these trajectories, remember that we can foresee and foretell death. Why don't we do it? Well, as I said earlier, diagnosis, therapeutics, and prognosis were uh, equally important till the middle of the 20th century, but somewhere prognosis dropped off our list of duties because prognosis is foreseeing and foretelling needs honesty, accuracy, and optimism, and we find it difficult to do. Unfortunately, what we don't realize is that if you don't foretell, you also lose foresight. And what do you discuss when you talk about uh, this kind of when you have this discussion about end of life care? Now, this is split into three aspects, related terms which we use. The first is goals of care. Goals of care is our responsibility. You basically are educating the patient and family about what is likely to happen. And goals, what do you want? Like Our Lady said, I do not want to go to hospital. That has to be settled. And it need not happen in one single consultation. It can take multiple visits. When these goals of care are made actionable in a system, and that system will include choosing a proxy decision maker, a surrogate decision maker, which is legally valid and backed by public policy, a whole system, then we call it advanced care planning. So the minimal part of that is the living will or the advanced medical directive, but when it all works, it is advanced care planning. And if you do it right, then you have shared decision making where you combine the patient's or the family's inputs about values and preferences with our input as doctors, prognosis, and so on, so that we take appropriate decisions as and when it is required. To set goals of care, explanation and communication is crucial. You have to find out how much they want to understand, but you also have to ask them how much do they want to know. There are times when they'll say, "We don't want to know anything. Just make sure that he or I do not suffer." We have to explain uncertainty, and we have to just focus on trends. The crucial decision that you have to take is to find out patients' wishes about place of care and whether the caregiver agrees, and then you have to figure out how that works. Now, these wishes and plans may change. If you do it right, it improves patients' quality of life because they get a sense of control over the last days. It reduces conflict and stress among surviving family members, and it decreases use of unwanted ICU at the end of life. The challenges are from the patient is fear of death and difficult to in thinking and talking about these issues, and for clinician, lack of time or difficulty in discussing food process. So the specific decisions that we need to take are preferred place of care of death, the mode of feeding when the patient is unable to take uh, oral feeds, which means do you put in a feeding tube or not, parenteral medications, and life-saving treatments like CPR, invasive ventilation, dialysis, etc. Now, if you look at, go back to the last patient, you see, families do not see the timeline of decline. The sentinel event occurred a year or almost about 7, 8 months before. That was maybe up in the previous year, the first her fracture neck was a death. And then she developed these multiple skin abscesses. Then she developed reduced activities. And then finally, it became, well, she went into what is called active dying. Um, so as clinicians, we should be aware of this. But the problem is clinicians either do not see it or see it and ignore it, or don't know how to handle it. And as I said earlier, if you do not know how to foretell, your foresight will atrophy, your skills of prognostication will atrophy. And this takes in a learned skill, that is communication skill. Communication skill takes training, which means you need a mentor, you need to be supervised, then you need to practice, reflect on what you do, and then you need assessment and certification until finally with you reach the stage of being a guru where you can perform. And you keep doing this over and over again. And it is one of those skills that as you do it, you obviously improve. So why don't people do it? Now, this is me having a conversation with one of my senior colleagues who's much bigger than I am. He is, are you telling me that I need to learn communication skills? It's like that. So I'm going to actually jump past these slides because this was part of a different program. And I am, if anybody is interested, you can always, sorry, what happened to this? Sorry, I need to reshare this. Give me a minute. Are there any questions so far?
Not in chat. Anyone wishes to ask a question now?
Right, it's okay. So we shall, why is this? Oh, sorry, I'm on Google Slides and I'm going to stop sharing and then open the, and then come back again because I think I will need to start. These are best delineated for malignancy. So active dying are the hours or days preceding death during which time the patient's physiological functions wane, and we have to prepare the family and caregivers, and you need to see that the care is holistic and includes after that care and bereavement support. Months to weeks before death, we call it pre-active dying. Physical and psychosocial withdrawal begins. Ambulation decreases, people withdraw from family and friends. And these are, as I said, physical and psychosocial. Intake is reduced, occasional incontinence happens. So these are all the signs that we have seen earlier. Then, when active dying begins, what we notice is actually encephalopathy or delirium. So there are episodes of confusion and vital signs start to drift down. There's increasing drowsiness, oral intake decreases, and this happens weeks to days before death. And communication ability also goes down. Days to hours before death, with imminent death, you have deteriorating vital signs. Consciousness goes, breathing becomes irregular. Because secretions cannot be swallowed, you have the death rattle because of secretions pooled in the throat. There's weak pulse, wool, clammy extremities, mottling. The face may become slack and may start to look yellow. So at this stage, our goals in caring, as we've already said, are to ensure the patient's comfort, to make the end of life peaceful and dignified, and manage symptoms. One of the things that is pretty important for us to do is to uh, is medications dosing. So you have to review the drug charts, remove the drugs that are not necessary, and focus on symptom control. Um some challenges come up fairly early. The first are challenges for oral intake. Uh, Appetite goes down. There's food aversion, nausea. There may be stomatitis, pharyngitis, and families focus on intake because they see intake as being crucial to life. What they don't realize is that it is actually the other way around. Because the body is shutting down, that is why nutrition and hydration is not required. So feeding tubes do not enhance survival or quality of life at the end. In fact, they are associated with agitation, increasing restraints, and then they get ulcers, and it doesn't change the risk of aspiration. So you have to make these decisions based on the patient's overall best interests and quality of life. If you do need to give clinically assisted nutrition and hydration, you have to make sure that overhydration is avoided, because having a bloated um, body with no output is bad. It adds to the suffering. So what we recommend instead is careful hand feeding, providing food items which are mashed, uh, and you don't need to add nutritional supplements. It can be just normal food. In fact, this hand feeding is more for the family's comfort than for the patient's requirement. Symptoms of thirst can be alleviated with good mouth and ice pieces to moisten the lips. Body is shut down. Fluid requirement actually drops to about 1 liter per day. And what I tell families is uh, that rather than uh, sorry, rather than worry about how much is going in, confirm that the patient is passing urine at least 4 times per day, and that the urine is normal colored. Not so if they are passing 1 or 2 times and very high colored urine, then you know that uh, things have deteriorated. Um, Again, the same thing for IV fluids, and we try and do this hand feeding bit. All medicines that are not required for symptom control have to be stopped, because any medicine that needs to be continued has to be given subcutaneously. So IV antibiotics, aspirin, statins, vitamins, even insulin, because there is no intake and the sugars usually tend to drift downwards. All of these can be stopped. Now, the symptoms that bother the patient and the family are pain, agitation, incontinence, and dyspnea also, but sweating and fever and other things. And you have to take care of all of them. So the best way to deliver medications at this stage is by the subcutaneous route, but you can use sublingual or transdermal also. But as I said, palliative care, the subcutaneous route is the standard one. The most common symptom is pain, and you have to sometimes use non-verbal measures. There's a scale for assessing pain in people who are, say, for instance, in severe dementia. And these are non-verbal measures. And you have to anticipate and treat the pain effectively. So opioids, either oral or subcutaneous. Oral, obviously, this is a stage. At this stage, you will need some way of putting them in, or the patient has to swallow. That's why usually subcutaneous. Restlessness, agitation, delirium. Well, first of all, look for obvious causes. And I always ask my students to look out for fever, urinary retention, constipation, and pain. And if these are taken care of, then most uh, correctable causes are done. And you stop stimulating noise, you put familiar objects in the patient, and you protect the patient's sleep uh, with careful communication. But if it is not getting controlled, then you need to use haloperidol. Benzodiazepines can worsen delirium, and they're never the first choice. What about breathlessness? There are four principles. You correct the correctable. So, for instance, if fluorescentis is required, you do that. Then remember to use air movement on the face with the fan. That improves symptoms. Reduce the perception or the worry of dyspnea, and for that you need morphine and anxiolytics. This is an indication for benzodiazepines, but morphine probably works better. And when the breathlessness is refractory, then you use palliative sedation. And we'll talk about that later. This reversible principle also applies to nausea and vomiting, where you should take care of constipation and hypocalcemia, etc. But if that is not obviously there, then you use the first line drugs. In neurology, we generally prefer ondansetron, but adjuvant drugs that can be used are dexamethasone, lorazepam, cyclizine, olanzapine, and uh, typically you need to get. I mean, people are. You need to get this controlled as fast as possible. What about the death rattle? This is because of pooled secretions. And here, the family education is important. They have to be told this is not causing any distress to the patient. Management can be non-pharmacological by repositioning and removing the secretions from the angle of the mouth. We avoid suctioning because it's uncomfortable and actually irritates the oral mucosa. Pharmacologically, we can use glycopyrrolate uh, and hyoscine. We avoid scopolamine because of its anticholinergic side effects. Uh, Other nursing interventions like mouth care, pressure sore prevention, Foley's catheterization, etc., are all need to be carried out. And at the end, the family needs to be prepared. Now, if you remember my last patient, she quietly drifted away, just stopped. But there are two dramatic ways uh, for death to occur. In patients with neurological illnesses, they can start getting fits. And the important thing is to prevent harm. You cannot use oral medication, so you have to ask for subcute midazolam or other anti-epileptic drugs. And if it is already decided that the patient will not be moved to hospital, remember that as status goes on, the patient becomes unconscious, quiet, and will stop. But the most dramatic is the blowout hemorrhage. This is because oral malignancy can infiltrate the neck arteries, and this people have to be warned about. Because once it begins, before you know it, there's huge quantities of blood everywhere. So you have to keep dark towels, preferably green, around so that the blood is not seen, and you have to quickly sedate the patient. In some situations, especially breathlessness or pain, the symptoms are just not controlled, and you then need palliative sedation. Palliative sedation means that you use a sedative with the goal of light sleep and comfort, and the natural process of dying continues. Unfortunately, when you sedate, you may hasten death, and then this is called This is called double effect. And if you are managing to keep the patient suffering under control, hastening death is an acceptable double effect. This is, in that sense, very different from euthanasia, where the intent is to terminate life and death is actively accelerated. Remember that the family may be suffering as much and maybe even more than the patient, so you have to address their needs. And if death occurs at home, you need to do a systematic job of confirming it, confirming identity, confirming the absence of signs of life, and then documentation. In palliative care, some of the other issues that are important are to collect unused opioids. And we also do what is termed a bereavement visit, or at least a phone call to the family, because the family needs support. And they have to be explained that grief is a wave-like phenomenon. So there are times when the grief will really burden them, and then it will sink down again. And they have to take themselves through those periods when the wave is at its peak. Normal grief lasts about 6 months, and when it crosses that period, that's called complicated grief, and it verges into depression. So remember that the family anticipatory guidance will prevent panic. Uh, you have to be available to answer questions, and you have to listen, and you have to assure them that symptom control will continue. Whatever religious or other wishes they may have, you have to help fulfill them. And if need be, you can do it with the medical team and the community. Now, bereavement is the period during which mourning and grief occurs. Grief is the natural distress, mourning is the outward expression of that, and everyone will experience grief uniquely based on culture, religion, the nature of loss, sudden versus expected death, and the relationship to the deceased. So, types of grief, anticipatory grief occurs before death. Acute and integrated grief we've already spoken about. Complicated grief is when 6 months to a year after that, it has still completely taken over the life of the person who's grieving. We leave this. So key messages are that terminal illness can be identified. Focus has to shift to symptom control and quality of life. Active dying has to be recognized and the family must be prepared. And remember that family support begins before death and continues afterwards. Now, I have been involved in this project since March 2011. I was in the medical team that examined Aruna Shanbag. You may be aware of that. And one of the projects that my group has focused on is to make a basic living will, an advanced medical directive for India. You will get this on the Pallium India website. If you type in Pallium India Living Will, you will come to this page and you will be able to download this. We made it applicable and simple enough for Indians. And remember that even though there are issues with uh, uh, currently about how to make it enforceable, the process of making sure that your family knows about it, make sure that a lot of problems are avoided towards the end. If any one of you wishes to do it, you're welcome to connect with me. But more importantly, you have to begin by speaking to those close to you. You have to choose your surrogates, confirm that they accept the responsibility, understand your wishes, and will follow them. The advanced medical directive has to be signed in front of 2 witnesses, and as of now, it has to be attested by a judicial magistrate first class. We are working on that, but this is really not negotiable. This must be done. I tell patients that they must show it to every doctor that they consult, because they'll find out if the doctor is willing to accept it and support the patient. The doctor will find out what their hospital's policy is so that you'll know where to get admitted, and the doctor will know your own wishes. I'm going to stop at this point. My email ID is here, and I'm happy to take questions as well as answer any queries if you email me. Thank you.
Thank you, Dr. Roop, for that wonderful presentation. Any doubts to Dr. Roop?
Right. While the case is being set up, I'm just going to take a quick break for a little bit of water. My throat is a little dry. Are there any questions? Please just, are they putting them up in the chat box or anywhere?
Either way can be done. You can either put the questions in chat or you can unmute.
Yeah, so let's give them let's give them a few minutes to put them in the chat box first. Otherwise, then they can unmute and speak.
Sure.
I'm just coming in a minute. Hello, am I audible?
Yes, Doctor, you are audible. We didn't get any questions yet.
Okay. So we go on to the case.
Yes, sir, we can move on to the case. Dr. Vaidyanar, yes, sir, you can start your presentation.
Yeah, thank you. Good afternoon, sir. Good afternoon, everybody. So I'm Dr. Vaidyanathan. I'm from Mysore. Here I'm going to present a case on for discussion of end of life care. Next slide. Yeah, we had an elderly gentleman with advanced Parkinsonism who presented us with aspiration pneumonitis and respiratory failure. So he presented with shortness of breath since 2 days, which had worsened since the morning. He had history of altered sensorium, which was there for more than a week. was not tolerating oral feeds for the past 8 to 10 days. He had swelling of both the lower limbs for the past 15 days. He had generalized tiredness and debility, which was there for close to a month. Next slide. Yeah, he was a known case of Parkinson's plus syndrome and was on treatment. He has been bedbound for more than 1.5 years now. Because of the prevailing COVID situation, he lost follow-up with the neurologist. He was non-ambulant and he was not taking oral foods. He had worsening sensorium and shortness of breath for the past 2 days. He was assessed by a family doctor and he was referred to us for ICU care, and he looked at his saturation and he was breathless. So he was told, the patient's relatives were told that he requires intubation, ventilator support, and ICU. Yes, sir.
Can I interrupt at this point?
Yes.
Can we go back? First is, of course, right. Go back one slide more. Right. Any points that you would like to make just based on this?
Myself, sir?
Yeah. Why don't you try it? You actually gave some of the answers a little ahead. Typically, if you remember what I talked about when people die, if you
Yes,
remember,
sir.
I said that
Yes, they stop taking oral feeds.
60s are for cancer, 70s are for multi-organ, and 80s are for frailty. So typically, Parkinsonian patients die somewhere between the 70s and the 80s.
Yes,
So
sir.
you can see that this guy is already a decade ahead. He's actually a decade ahead of where you would expect him to actually pass away.
Yes, sir.
Actually reach this stage. Next, go on to the next slide. Right. So, does this give you a sense of what is happening? Swelling of both lower limbs, obviously hyperproteinemia. I'm sure the albumin had already dropped. Oral feeding had dropped down, altered sensorium. So, I mean, if you know, you know where this.
It's an active dying.
Where the you know where the story is heading. Next slide. And if you remember what I had told you, he was already terminal for at least a year or so.
Yes, sir.
So, and he was assessed by the family doctor and referred for ICU care, which I think perhaps was not the right decision. But anyway, go on.
Yes, sir. So, on general examination, he was drowsy, was poorly arousable. There was generalized debility and wasting. He had tachycardia. The pulse at that point was regular. BP was 110/70. He had obvious respiratory distress with tachypnea, and he was using his accessory muscles of respiration and ingoing of intercostal muscles. At that point of time on admission, the saturation was 48, which increased to 85% with 100% oxygen with non-reserve breathing mask. GCS was E1, V1, M4. Pupils were normal and reactive. He had extensive bed sores over the back and sacrum, though it was grade 1 to 2, not bone depth. He had contractures in both the lower limb, but he was moving all 4 limbs to pain. Plantar were flexor. CVS was clinically okay other than tachycardia. Respiratory system, he had bilateral conductive sounds and crepitations. Abdomen was soft. Next one, next slide. Yeah, the basic investigation didn't reveal anything much except that he had a mild pre-renal failure and his blood sugars were a little high. This patient met me some 3 months back. So at that time, probably a COVID screening was mandatory in our hospital to getting admitted. So his COVID screening was done, which was negative. So the CT thorax had patchy consultation in the right lung and mid lower zones. We got a ECG which had shown Q waves, probably which was suggestive of previous MI. By the time he had some amount of AF also. Next slide, please. Yeah. So coming to the psychosocial aspect, this patient had 3 kids. All of them were grown up and they were all financially independent. They were willing to do everything for him. This patient has been bedbound for almost close to 2 years, and he has been lost with the neurologist for follow-up because of the COVID restrictions and all. Unfortunately, the relatives have been counseled by a very close family physician and a friend telling that he needs ICU admission and ventilation. So it was a little challenging for us to make them understand the futility of aggressive care and plan for a good palliation. Next slide, please. Yeah, so the patient was promptly started on oxygen supplementation with reservoir bag. He was started on antibiotic in view of the aspiration pneumonitis. Diuretics was started and it was advised SOS. So his antiplatelets, Parkinson medications and antihypertensives were continued. Next slide. Yeah. So our main concerns were how to initiate the discussion of end of life care, especially when they were probably not receptive at that stage, especially when someone else has told them that he may need intubation, ventilation, and all. And to make them understand the futility of the aggressive management in the form of intubation or ventilation, in view of his long-standing progressive Parkinson's, debility, probable hypoxic brain damage at that time, generalized poor organ reserves and organ failures, and to provide him comfort care with respect to the patient's problems, to decrease the distress, to address his best source, and to give pain relief. Most important thing was to involve the patient's relatives at this point of time in decision making, since we didn't get any patient's advance directives, or we really didn't know what he would have expected or wanted at that point of time. Next slide, please. So in summary, we have had an advanced Parkinson's plus patient with generalized debility who has been bedbound for some time with multiple organ involvement, aspiration pneumonitis, severe hypoxia, and respiratory distress. He had severe contractures, bed sores, and poor organ reserves. He had been referred with a specific advice that he requires intubation and ventilator support and ICU care by the primary care physician. So assessment of the patient was done and end of life care issues were discussed with the relatives, though in phases. Initially, it was very difficult to straight away tell that, see, your patient is going to die. Nothing can be done. It was very difficult. So we admitted him to ICU. We started him antibiotics. We provided him comfort care. Then we opened up the discussion. Then we took multiple sessions. Then they took some time. They wanted to consult with their relatives. Then again, they came back. Then after third sitting of discussion, finally, we agreed that he needs palliative care. So that's how we went about it. So slowly, as the patient's relatives understood the futility and the need for end of life care, so the patient was shifted to the ward with oxygen, with the relatives being this side. Provision to have religious priests or the clergyman was discussed with the relatives, but they refused it. So the patient breath is lost later in the day, the same midnight. Next slide, please. Yeah, the discussion points. This I had made at the point of time when I had made this case presentation and slides were submitted probably some 3 months back. So the thing was identification of the dying process and initiation of UL care, which has been clearly told in your presentation how we can do. My doubt at that point of time was, is there an element of subjectivity? So it was always there. The primary care physician feels that I'm not being sufficiently enough. I feel probably it is the right time for UL. So probably I thought there has to be some discussion there. So we cannot be subject to, there has to be objective assessment of the dying process or to initiate the patient on UOL. That was my thing. We have got multiple guidelines, but can be streamlined. Can we have a streamlining of policies by which we can ensure, especially when to withhold life support? Somebody has told he needs ventilation. I'm here to say, no, I'm not going to do anything. We're withholding the life support. So can we have a little more light on those things? Any update on the legal and medical legal hassles? Like it has happened to me. Once what has happened, we had withheld the life support. 1 week later, once all those grief and bereavement, everything was done, one more person came and he says, see, doctor, I am the son of his second wife. And how can you allow even this to happen? Those people, what they have done with you is they have cheated and they wanted to take out all the property by themselves. And they just cried and you got carried away with this. How you can even allow this to happen? I was speechless. I just didn't know. Then I just took some time and said, we'll address. And he didn't come back. So it has happened to me before. Sitting in ICU, we have different levels of withholding life support, like withholding intubation, which is fairly easy. Withholding dialysis sometimes a little tricky. Most of them they say no for dialysis, so it is tricky. We feel probably 1 or 2 dialysis may help or may not help. Our trial of dialysis probably would be the right way to go when we are thinking whether we have something on withholding dialysis. Withholding vasopressors, again, which we don't usually do. And should we still go at it treating or bother about initiating the patient on antibiotics once we have already decided? Again, you have told very clearly about the medication chart, how we have to review, and details on the prescription of EOL care. We have said EOL care, probably not many may be aware of what exactly is EOL and how we're about to go about these things. These are all some of the things which came to mind at that time. So next slide. I think that's the last one.
So, okay. Somebody had a question.
Yes.
Yeah, so Dr. Raju has asked about my take on private hospitals prolonging ICU care. So let me explain to you that if you are looking at revenue generation, typically when a patient comes into the ICU, it's the first 3 to 5 days when maximum interventions are done, when revenue happens. And it really is not worthwhile, even for a private hospital, to keep a patient hanging on in the ICU. It doesn't make sense. Amongst other things, you have an infected patient there, not a good idea. There is an element of moral injury because everybody knows that this is futile care. So it's not again good for the morale of the doctors. So the way we handle it, and that's another of the questions that was raised by Dr. Raju, the standard is what is termed a negotiated trial of ICU therapy, 3-5 days. So typically in a situation like this, if I were forced to intubate, I would say that I might intubate, but I will review after 3 days. And if it is not working, then proceed. Now, when you look at the question of extubation versus withholding intubation, uh, legally, uh, not in India yet, but almost everywhere, withdrawal is and withholding are looked on as ethically equivalent. So when you withdraw, you're basically withholding from that point on. You're comfortable withholding. So actually speaking, there should be no difference between withholding and withdrawing. But I see this routinely, for instance, in patients who have severe brain injuries, and they are intubated. You know that they are going to have a terrible quality of life, but it looks like a tracheostomy is inevitable. So typically, this is the kind of patient where I will leave this discussion open till about the 10 to 14 day. I tell the families that extubation is my decision because the endotracheal tube has to come out. There's a medical reason for it. But they have the right to withhold tracheostomy if they feel so. And typically patients' families will take that. They will accept that they will be withholding tracheostomy. But if I were to turn it around and say, I will extubate on your say so, they would say no. So you have to frame it as withholding. Now, there are other multiple questions that you have raised. Would you want to take on anything specifically, or should I kind of just go over the legal framework that we now have? Anybody else wants to unmute, and otherwise I'll go on to the legal framework. Hello?
Yes, sir. You can take on the legal things first.
Yeah. Okay. So look at it in one way that our whole understanding of patients' rights and so on are linked to human rights. It was literally after the end of the Second World War, just about the time of our independence, that the Nazi stories came out, and that's where human rights became obvious. And then over the next 2 decades or so, it translated into patients' rights. And then it translated further into patients' rights at the end of life. And especially in the US, it became a very prominent thing to have living wills. And politicians also got into that. So everywhere across the US, you had living wills which were actually statutorily available. India, for whatever reason, it took us, our Supreme Court, some time before they also kind of saw this. We were about 20, 30 years behind. But in 2018, there was a landmark judgment which said that the right to live with dignity also includes the right to die with dignity. And that if somebody chooses not to accept any treatment in conscious state of mind, even if it causes that person's death, you cannot enforce that treatment. So this would mean if somebody has expressed their wishes to not take life supporting treatment, then it should not be enforced. But the Supreme Court actually in that judgment went a little further and said that even people who have not expressed such a wish, if they're surrogates who are valid, uh, uh, express that wish for them, this can be enforced. So this is where we come to the question of whether withholding and withdrawal is feasible in India or not. Unfortunately, the Supreme Court did not want to make it open. They did not want to do something that the government should be doing, because basically it is the government's responsibility to put together a law which sets out the framework for this decision making. You know, a judgment can only do so much. A judgment is not a law. It's only laws that say, thou shalt not, on pain of the punishment and so on. So until that happens, We have only the Supreme Court judgment to go by, but please understand that that has made it this kind of decision making, uh, in a sense, constitutionally valid. The only thing is that they have asked for you to go through multiple processes. The first process is within the hospital. The second process is a medical team that is supra hospital, and the third is a process that goes into the district collector and the judicial magistrate. So, to my knowledge, nobody has gone through the whole process. So, what we suggest is that if you are going through end of life care decision making, first make sure that you have consensus on the treating team. And this does not mean a consultant and his registrars. It means a minimum of 3 consultants who should be able to, willing to sign out, saying that this is now futile care. On the other side, the family side, the surrogate side, there has to be, you have to check the hierarchy. So the surrogate hierarchy, first is the spouse. There is an AIMS document which also says partner and so on and other. It gives other options. So, which is where your first and second wife question could probably have been sorted out. If not, the spouse, then after the spouse are adult children, then are adult siblings or parents, and so on. So, this hierarchy, if you look it up, is now set out in the AIMS guidelines. As of now, even the Organ Transplant Act doesn't tell you what are valid surrogates. So it's only the AIMS guidelines which has finally laid this down. And since it is a statutory body, I suggest we can follow that. Now, you have to do your due diligence and make sure that the appropriate surrogates have been contacted. And typically, we need the spouse and the subsequent minimum 3 surrogates to sign out or to be in consensus. If there is no consensus on either side or between the 2 sides, the process stops. If there is consensus on both sides, I mean, within the 2 sides and between the sides, which is the case in actually 90 to 95% of cases, then you go ahead. But you must document this discussion, and it has to be transparent. You have to, the way you handled it in this case was completely transparent. And through that discussion, you reach the appropriate conclusion. So, but you understand that for most of this, the crucial requirement is a physician who's aware of his or her duties at the end of life, is willing to prognosticate, is willing to communicate that prognosis. And that, unfortunately, I wish there were more like you around. Right?
Yes, sir. Thank you. What about different levels of withholding, sir? Vasopressors and dialysis. What is like?
Ventilation. So DNAR is very, very clear cut. So now typically when we begin this process of discussion, typically our palliative care team, as they come in, our palliative care physician first and clearly takes a DNAR signature from the family. Once they've done the DNAR, within a day or two, once they've signed it out, typically they start thinking about the other things also. And you'll see that the other things follow after that. That's the logistics of getting it done. But effectively, everything is in the same boat. Whether it's dialysis, whether it's ventilation, whether it's IV antibiotics, whether it is even rice tube feeding. They're all in the same category. So what we tell them is that we will not do anything unnatural and we will allow natural death. And of course, families find it very difficult to accept stopping nutrition and hydration. So that is probably the last thing that we pull out. But we cut it down to about a liter or less per day.
Anything specific about the prescription of EOL care, sir? It's like we have shifted the patient to ward now. Do you have any standardized prescription for?
Yeah. So typically it will be amount of fluid per day uh, total fluid intake. Then it will be provision of morphine, depending on provision of midazolam for SOS use. And these are, I mean, if there is additional doses of anything else, if there is delirium, then haloperidol, except of course in a Parkinsonian patient, you would not have used haloperidol if at all. If it was persistent, you would have to use clozapine. Then nausea, vomiting, whatever is required appropriately, whatever is working. All those, these are symptom controls as they are required. You continue and you put them on SOS basis as well.
Thank you, sir.
Any further questions to Dr. Roop?
Yeah, this was this bit about ICU versus hospital versus home. This is something that varies from family to family. There are families which at some point say that they would like to be present with the patient towards the last days. There are families who say that we would like him to be at home, or that was his wish. And then it also depends on your ability to provide palliative care at home, or to have a doctor, GP there who will follow up and manage whatever is needed to be done for symptom control. So that is case by case. Yeah. Right. Anything else? Rajalakshmi, anything more, or we are done?
No, I think I was just waiting for participants if there is any questions or coming. I guess there isn't.